Shall we start, sir?
Yes.
Shall we?
Yes, President.
Good evening and welcome to everyone. Today, the 40th edition of our Pudukkottai Budan, an online weekly academic program from Indian Society of Anesthesiologists Pudukkottai. We are starting the 40th session today. Today, we have planned for basics of anesthesia, especially physics for anesthesiologists. At the outset, I invite our Honorary Secretary Dr. M. Periyasamy to give the welcome address. Over to Dr. Periyasamy. Dr. Periyasamy, please.
Periyasamy, you are muted.
Respected academic chairman, president and treasurer, members of ISA and delegates, those who are attending this 40th ISA online webinar program. On behalf of ISA, Indian Society of Anesthesiologists Pudukkottai, I welcome you all for this Pudukkottai Budan 40th online ISA webinar program. So already we are having very long memory and events from 23rd of March 2022. That is the date we started this online program. From that date, continuously we are conducting so many programs in various topics, important topics to benefit the postgraduate as well as practicing anesthesiologists in the academic part of the anesthesia program. So today we are entered the 40th ISA online webinar program, and we are having three basic important topics today. One is physics in anesthesia pertaining to cases and fluids, and next one is applied physiology in monitoring, and third one is fire and electrical safety in operating room. Basic topics everyone must know, and I invite SB Gangadhar. Welcome. And another, we are having three important speakers. One is Dr. Anush Gupta, Director Professor, Lady Harding's Medical College, New Delhi. Madam is going to talk about physics in anesthesia pertaining to gases and fluids. Welcome you, madam. And next topic is applied physiology in monitoring. For that, I invite Dr. Nishan Kumar, Professor, Lady Harding's Medical College, New Delhi. I welcome you. Welcome you, sir. And third topic is going to talk by Dr. Manuskani, resident, Lady Harding's Medical College, New Delhi.
Periyasamy, your voice is not heard. Periyasamy, your voice is not heard. President, sir.
Yes.
You can go for presidential address.
Okay. Dear Secretary.
Dr. Gangadhar joined.
Sorry. I joined again.
Yeah.
Collectively, they rejected this following programs of late, and I
Periyasamy, it is
Yes, sir,
creating a hiccup.
Yes, sir, coming back. Okay, sir.
Okay.
screen share is okay? Sir, I am audible.
Yes, yes.
So of late we are having some problem with the Tamil Nadu Medical Council. They collectively rejected these following CMB programs, though we applied yearly, and they send the message your application for CMB program got rejected by Tamil Nadu Medical Council. For that, it is very difficult to get these credit hours in future because they want to make us to apply 5 days prior to the program. So I appeal for that. Most probably they will give credit hours. If it's not possible, I think we have to think about this. Thank you very much with this. I conclude this my session. Over to President.
Thank you, Dr. Periyasamy, for your welcome address. Respected Academic Chairman, Dr. A.L. Meenachi Sundaram, sir. Treasurer, Dr. David. Members of ISA Pudukkottai branch. Members and office bearers of ISA state branch and other branches who are assembled here. Once again, I welcome our chairperson, Dr. Gangadhar, sir, for joining us today's event and waiting to give the valuable inputs in this session. I once again welcome our speakers from Lady Hardinge Medical College, New Delhi, who are going to talk on physics for anesthesiologists, especially Dr. Anshu Gupta, Director and Professor of Anesthesiology at Lady Hardinge Medical College. I welcome you, madam. And I hope you are going to deliver on gases and fluids, physics of gases and fluids applied to anesthesia. I welcome Dr. Nishant Kumar, Professor of Anesthesiology from Lady Hardinge Medical College, who is going to deliver on applied physics for monitoring. And last but not the least, Dr. Megha, resident from the same college, Lady Hardinge Medical College, who will talk about fire and safety precautions you have to undergo in operating room. The session of Pudukkottai Budan, we have given the basic topic. I once again thank the topics chosen for this session by our academic chairman, Dr. A.L.M. sir. And we are witnessed so many topics from all the fields of anesthesiologists for this 40 sessions. Now we are the 40th session, and hope in future also we will cover the left out topics. I hand over the proceedings to Dr. A.L.M. Meenachi Sundaram sir to conduct this session. Thank you. Over to Dr.
Thank you, Dr. Suresh Kumar, President ISA, Dr. Periyasamy, Secretary ISA Pudukkottai, and the distinguished delegates, and the topmost faculty of the country, 4 faculty we are having now. So today I am very happy because this is the first time 2 participants are repeating their performance. That means they have done par excellence. That is Dr. Nishant and Dr. Anshu madam, because they have already done Pudukkottai Budan for thoracic anesthesia. And when I approached Dr. Nishant Kumar the first time, when he has delivered it fantastically well, both he and madam, I said that you have done well, but they opted, whenever you want our help, we will help you. That's what they have done now. I met Dr. Nishant in Kochi, and I explained that these are all the areas not touched. So he and madam willfully agreed to talk on physics. So Pudukkottai Budan can take a credit because we have organized seminars on blood transfusion and this physics, untouched areas. I think the only untouched area for us is only the inventions, that is the scientists. All the other area we have touched. And today, the youngest faculty, Dr. Megha, our resident, she is too good. Last time also, the Lady Hardinge Medical College postgraduate has done very well under these 2 eminent professors' guidance. She has done on a WM and endotracheal tube, still I remember. And this time, this postgraduate has taken up physics, that is electrical hazards in the OT. That is a question for postgraduates, but a PG should have the guts to talk about it. and I really appreciate her. She's a third-year resident in Lady Harding Medical College. And see, the thing is, she's interested in reading novels. So whenever she reads a novel, I think she will imagine a fire in electrical hazard in the OT, and she imagine things. So that is surprising that she is reading a novel. At the same time, she is engaging in anesthesia activities. Even today, just like a Hitchcock novels, she stunned me. I requested her, Madam, you have to log in. It is 5:45. She asked me, shall I do it now? So that is a question, the reply I got from her. So definitely she is interested in reading a novel. We come to understand. And Dr. Nishant, we need not elaborate on him because he has proved his worth by his lecture, not by any introduction. So he is a professor in Lady Harding Medical College and he is associate editor IJA. And he is interested in all activities related to anesthesia. Mainly the thoracic anesthesia, low flow anesthesia, critical care. So he is so much interested in academics. That's what impressed me. And even now, when academics is concerned, he is behaving like a yesterday's postgraduate, not today's postgraduate. He mimics a yesterday's postgraduate, the keen interest he evinces in the anesthesia subject, the nuances he has to express his caliber. It is phenomenal. Really, I salute him for the academic interest he's showing. He should shine as a bright star ever in the academics of ISA. I wish him all the very best. And Dr. Anshu Madam, she is a director professor in the Lady Harding Medical College. See, both she and the Nishant, they have done numerous publications and they are peer interviewer for national and international journals. Madam, the peculiar part of it, Madam is trained and she is an instructor for all resuscitation courses. Say whether it is basic life support or advanced cardiac life support, and the American Heart Association, everything Madam does. And as it is really Lady Harding Medical College, she is the topmost lady heading the anesthesia department as a director and a professor. We welcome you, Madam, and we are very happy. And when the entire team from the northern part of India is taking part from Delhi, we wanted to have a best chairperson as far as possible. That too, it is dealing with physics. So we have picked up Dr. Gangadhar, who is a professor, Siddhartha Institute of Medical College, Tumkur, Karnataka. And see, he is such a lovely person. I asked him how you like to be introduced, and he replied me nothing because he thought he doesn't need any introduction. But formally, see, Dr. Gangadhar, see, he is keen academician, and the best part of him is he has organized a national conference in Bangalore. She was organizing secretary for the South Asian conference in Bangalore. He also has numerous publications. That and all any professor will have. But the good quality Dr. Gangadhar possesses is he is such a nice human being. And he is a bada kalakar. Lady Harding people go, मैं ये कहना चाहता हूँ, he is a bada kalakar है. He is a fan. He enjoys everything. See, you have to visit his house. He enjoyed everything, even in building a house, where it should be kept, everything. See, in his house, everything is neat and clean. But in my house, only the dustbin will be clean. We will not throw anything in the dustbin. So, but his house is, it is spick and span, everything is clean. I was wondering, and I said his house is like my dustbin. So in that way I can say, because my dustbin is always clean, nothing will be kept in that. So he is such a nice man. See, he owns nursing home also. He has so many extracurricular activities. He is interested in business, but in spite of everything, he still maintains a good human behavior and he possesses a good sense of humor. So whenever you ask him, he will answer very politely. Once you go to Bangalore only, you will know the potential of Dr. Gangadhar, but he always keeps himself cool. So that is the reason why I got affinity towards him, because people will be posing so much. We will be frightened to move towards some. So like Lady Harding Medical College people, Dr. Gangadhar is also keeping cool. And we are happy that you four are here. We have reached the 40th session. So I thank all the delegates who are extending their support for Pudukkottai Budan. We have to have some 3 more months to go. I request, and I am very happy whenever I am in distress, Dr. Nishant and Dr. Anshu madam will help me in times of need. So a friend in need is a friend indeed. I am having good friends. Thank you very much. I am handing over the proceedings to Dr. Gangadhar sir, our chairperson. Thank you, sir.
Good evening, sir. First of all, very much good evening, and Dr. ALM, I think has given. I think today only I am pronouncing as an ALM and all this thing. Otherwise, I used to call as an Meenakshi sir. That is the thing, because all our president and secretary, they told like that. Very interesting. And even little, this one regarding me has called. Thank you very much. So today, actually, the really interesting, this one, what you told, untouched subjects, you are taken out, you selected and all this thing. Definitely to talk this topic, definitely need that strength, need the really things. As you selected the speaker also, that is Hansu Gupta, is a director and professor from this. Really, really, really good. I think we can go on to the topic. We can start the topic.
PG.
Yes, yes.
First PG. First Dr. Megha.
Dr. Megha?
Yes.
Dr. Megha, unmute and talk. Any problem, Dr. Megha? Then I think another speaker can take over. Dr. Megha, is there any problem?
No, sir, can you hear me?
No, your slide share is not working. Your internet is unstable.
Yes.
I think better, can we go to the...
Yeah, Dr. Anshu madam. Anshu madam, are you ready, madam?
Yes, sir, I can start.
Yeah, so that she can get ready. Thank you, madam.
Should I try my sharing my screen?
Yes.
Yes.
Now Dr. Megha has shared it. Dr. Megha, yes, we can proceed.
Okay.
She just came like a mega.
Mm.
Megha has come as a lightning.
Sir, can you hear me? Can I start?
Yeah, yes.
Okay, sir. Good evening. My name is Megha Mansakhani, and I'm going to talk about fire and electrical safety in the operating room today.
Awesome.
We're discussing fire and electrical safety separately, each under the headings of introduction and general information, causes, prevention, and best practices. First, we will be talking about fire safety in the operating room. There are about 650 incidents of operating room fires in the US annually. Incidents in India is not exactly known. More and more of these incidents are being reported by the media nowadays, even though several guidelines exist regarding fire safety in the operating room, but most OR teams are either unaware of these or are untrained. Most common sites of fire on the patient are head, face, neck, and chest. Supplemental oxygen and oxygen supply are most commonly involved in operating room fires. Several misconceptions regarding OR fires exist, that they do not happen in today's hospitals. If fires do occur, that they were not preventable, that fires occur only at inferior facilities, and that all the OR staff knows what to do if a fire occurs. However, history is proof that such is not the case, and that these fires can occur anywhere at any time, and adequate training regarding OT fires is more often than not severely lacking. Fires in the OR can occur in the OR environment or on the patient. Fires in OR environment are mostly due to electrical equipment, and the first step, if these occurs, is to unplug the equipment and to remove the equipment from operating room. If fire is on the patient, in such cases, timing is of the utmost importance. A type of airway fires on the patient are airway fires are a type of fire on the patient, and timing here is especially critical. These are common in laser surgical procedures and carry a mortality of around 1 to 2 annually in the US. Their management is slightly different from other operating room fires. If an airway fire does occur, discontinue all gases immediately, remove the endotracheal tube and any residual burning items, pour saline into the airway, re-intubate and ventilate with medical air until no smoldering material is left, and only then switch to 100% oxygen. Certain equipment should always be present in the operating room for emergency situations. These include several containers of sterile saline, a CO2 fire extinguisher, replacement tracheal tubes, guides, masks, rigid laryngoscope blades, which may include rigid fiber optic laryngoscope also, replacement airway breathing circuits, lines, replacement drapes, and sponges should also be present. A fire extinguisher should always be present in an operating room. Its position should be clearly visible to all, and it should be clearly identified by a large sign. Fire extinguishers in ORs should be of the ABC type, which means that they should work against ordinary combustibles, flammable liquids, as well as live electrical equipment. The dry chemical fire retardant used most commonly in fire extinguishers is ammonium phosphate, which is mildly corrosive. Hence, where patient is the fuel source, a CO2 fire extinguisher is preferred as it does not contain ammonium phosphate. The correct technique to use a fire extinguisher is the PASS technique. The acronym stands for pull, pin, aim, squeeze, and sweep. Now coming to the fire triangle, which is an extremely important concept. Any OR fire requires three things: a fuel, an ignition source, and an oxidizer. Common fuels in the OR include alcohol or other skin preparation solutions, drapes, gowns, gauze, sponge, etc. Common ignition sources in the OR include electrosurgical units, lasers, fiber optic light sources, drills, defibrillators, etc. Common oxidizers in the OR are basic anesthetic gases which we use on a daily basis, that is, oxygen and nitrous oxide. Exists fire safety in the OR, and as a result of these, many institutions have begun to assign a fire risk assessment score as a part of surgical timeout. This checklist ensures that all members of the team consider the part they play in protecting patients from fire incidents. An example of fire risk assessment tool has been given here, and important for us as anesthetists are the high risk factors pertaining to our discipline mentioned here, which include surgical site above xiphoid, oxygen concentration more than 30% being used, such as the case is all GA cases, and nitrous oxide being used in mixture with oxygen. Certain interventions that we can perform to minimize fire risk have also been mentioned here, which include communication of risks during timeout, confirming no tunneling of drapes between oxygen-rich environment and surgical field, minimizing or discontinuing oxygen 1 minute prior to energy device use, titrating oxygen to lowest safe concentration, avoiding oxygen trapping with tenting of drapes or using open draping, utilization of cuffed and laser reinforced endotracheal tubes with methylene blue in cuff where appropriate. Fuel sources in the OR can be patient-dependent or patient-independent. Patient-dependent sources include hair, tissue, and intestinal gases. Patient-independent sources can be solutions such as those used for skin preparation, especially alcohol-based ones, materials such as drapes, gauze, sponge, and airway devices. It is important to note that even materials marked non-flammable become flammable in presence of high oxygen concentration. Prevention is better than cure, and certain steps can mitigate a disaster prior to its occurrence. These steps include utilizing a non-alcohol-based skin preparation solution, or at least avoiding cooling of alcohol-based skin preparation solutions, utilizing moistened surgical gauzes when appropriate, doing a mannitol-based bowel preparation, mechanical bowel preparation, with or without concomitant antibiotics when bowel surgery is indicated, and using laser-safe tubes in upper airway surgeries with careful attention to cuff integrity. ASA practice guidelines on operating room fires have comprehensive algorithm for prevention and management of OR fires. Prevention strategies and assessment of risk in the procedure has already been discussed. If it is a high-risk procedure, that is, if an ignition source will be used in close proximity to oxidizer, enriched atmosphere, then we should agree upon a team plan, and roles for preventing and managing a fire should be pre-assigned. We should notify surgeons of presence of or increase in an oxidizer enriched atmosphere. We should use cuffed ET tubes for surgery in the airway and appropriately prepare laser-resistant tubes if required. We should consider endotracheal intubation or laryngeal mask airways for monitored anesthesia care cases with moderate or deep sedation and or oxygen-dependent patients. Before ignition source is activated, we should announce intent to use ignition source. We should reduce oxygen concentration to minimum required to avoid hypoxia, and we should stop the use of nitrous. Even if no warning signs are present, we should be on the lookout for early warning signs of fire, which are unexpected flash, flame, smoke, or heat, unusual sounds such as pop, snap, foam, or any odor, unusual movement or discoloration of drapes or breathing circuits, unexpected patient movement or complaint. If warning signs are present, we should halt the procedure immediately and investigate further. If a fire is present on further investigation, we must first see if it involves the airway or not. Management of an airway fire has already been discussed above. If it is not an airway fire, we should stop the flow of airway gases, remove drapes and all burning materials, and extinguish the burning material. If fire is not extinguished after these steps, whether it is an airway fire or a not airway fire, then we should use a CO2 extinguisher. If even after that fire persists, we should activate fire alarm. We should evacuate the patient as per institutional protocol. We should close the OR door. We should turn off the gas supply to the room. After initial management of an airway fire, once ventilation has been re-established, we should avoid oxidizer-enriched atmosphere. We should examine the removed endotracheal tube to see if any fragments were left behind, and we should consider bronchoscopy. After a non-airway fire, we need to maintain ventilation. We need to assess for inhalational injury if the patient is not intubated, and here also we might need to consider bronchoscopy. Now we'll be talking about electrical safety in the operating room. Almost all the equipments in the operating room are powered by electricity. Anesthesia machines, ventilators, monitors, body warming devices, etc. All of these are powered by electricity. The four major ways in which this electrical supply can be hazardous to us are electrocution or macro shock, electric burns, electrochemical effects, fire, and explosions. Firstly, we'll talk about macro shock or electrocution. The thermal energy delivered to the body tissue is depending on the power. Power is equal to the voltage into the current, and this is equal to the square of current into the resistance. The resistance of the human body is least in the mucous membranes and most in the skin of the sole or a place where there is a hard callus. Presence of water or sweat decreases this resistance by approximately 10 times. At 50 Hertz frequency, a current of more than 30 milliampere can lead to respiratory muscle contractions, asphyxia, and finally death. A current between 70 to 100 milliamperes can lead to multifocal premature ventricular contractions, cardiac failures, local burns, or ventricular fibrillation. A current of more than 1000 milliamperes can lead to extensive burns and charring. If the current passes through the heart horizontally, it can lead to ventricular fibrillation, and sudden cardiac deaths can be due to this. If it passes vertically, there can be damage to cardiac muscles. Now we are coming to microshock. Small currents through the body also interfere with normal functioning of the muscles and nerves. A minimum of 50 milliampere current is required to produce ventricular fibrillation. However, if the equipment is close to the heart, then even a small current can cause ventricular fibrillation. Examples of these equipments are a pulmonary artery catheter which uses P-wave guidance. We know that the catheter is placed very close to the heart, a dialysis catheter, etc. Now coming to capacitance coupling. This occurs only when there is an alternating current, and it cannot be totally eliminated in any case. It can only be minimized by proper precautions. If there is an electrosurgical current present, then it can induce a stray current in nearby conductions. Examples of capacitance coupling are a non-MRI compatible pulse oximeter in MRI room can cause finger burns. If active electrode of cautery in laparoscopic surgery is in contact with a non-insulated laparoscope, and this is passed through a metal cannula and current flows through this, then it can flow through the patient abdomen and lead to burns. Now coming to electric burns. We know that passage of electric current generates heat, and this heat generated can cause either electric burns or fire and explosions in the operating room. Electric burns are most common with electrosurgical units. These can be unipolar or monopolar cautery and bipolar cautery or diathermy. In case with unipolar or monopolar cautery, it can lead to burns if there is absent or small grounding pad, if it is not gelled well, if it is applied over a small area, and if the contact is minimum because of a bony problem. Now we need to link current pathways in a monopolar and a bipolar cautery. In a monopolar cautery, the current passes from the electrosurgical unit to the patient's body to the return pad, which is placed separately on a large surface area part of the skin, and back to the electrosurgical unit. We use a device which is a probe, and current passes from the probe to the return pad and then back to the electrosurgical unit. However, in a bipolar cautery, the device used is a forceps, and the current passes from the electrosurgical unit to the patient's tissue from one end of the forceps back to the other end of the forceps and then back to the electrosurgical unit. We talk about protection of patient from shock. Is inserted in the circuit of electrical equipment connected to the patient. Alternatively, there can be COE LCB installation, which is operated at low earth leakage currents, is a fast and cheap method of protecting patients from shock. Classification of electrical equipment in medical practice. It can be class 1, 2, or 3. Class 1 involves common household equipment, which has only single insulation. Class 2 equipment has double insulation. And class 3 equipments are those which use a power source of lower than 24 volt AC current. And this you should be using certain precautions during use of electrical to avoid giving shock. We should avoid using where high concentration of oxygen is present, example tracheostomy. We should put it in standby mode when it is not in use. We should prefer bipolar cautery as it requires lower voltage. We should prefer that it be activated by an operator only when tip is in direct vision. It should not be activated if the tip is not in direct vision. We should keep the setting such that minimum effective power is used. Foot space clutter should be minimized because it reduces chances of accident. We should use it very cautiously where metal cannulas are used in laparoscopic surgeries. As we have discussed, it can lead to capacitance coupling and passage of current to the patient. The probe should be kept safely away when it is not in use, and the tip should be cleaned regularly. Certain precautions should also be used when pre-gel dispersing electrode is being used, which is the cautery pad. We should check it prior to application of jelly. We should apply it to a clear, dry, non-hairy area with good contact to large skin surface as near the surgical field as possible. If this cautery pad is damaged, outdated, or old or open, we should discard it and use another one. We should use pads of appropriate size. It is available in neonate, infant, pediatric sizes as well. We should never reuse it. We should apply ECG electrodes as far as possible to avoid AC currents passing through them. There are certain other standard precautions which should be taken in the operating room to minimize current passage to the patient or to the hospital personnel. There should be a metal chain with at least 3 links in contact with the ground dangling from the anesthesia machine to the floor. The footwear which is worn by operating room personnel should be made of a conducting material. All the mobile medical equipment must be in contact with the ground. All anesthesia equipment such as masks and circuits should have conducting material. We should maintain all our electrical equipment regularly. These steps can minimize electrical hazards in the operating room. Thank you.
Thank you, Dr. Hello. Thank you, Dr. Megha, for extensive talk on the fire and electrical safety in the operation room. You extensively covered the problem, this one also. Actually, already the TLM is told that normally we used to get as a long question for this, that is the safety in the operation. You covered up very nicely, and you're not left point any other things and all this thing. Really, it is a wonderful, and we are going to take up the questions and all this thing. End of all the speakers have completed their talks, so we can move on to. We can move on to the next speaker, please. I think Dr. Anusha Gupta.
Yes, sir.
Can you move on to your talk?
Yes, sir. So
Okay.
I'll share my screen, sir.
Okay. I think regarding Anusha Gupta, regarding that Dr. ALM has told and all this thing, physics in anesthesia. It is one of the toughest things. Even anesthetists feel that physics in anesthesia, and majority time they're not going to cover up. I think today with us is the name Anusha Gupta. She's a director and professor of Lady Ordin, Delhi. That is the thing to talk about the physics in anesthesia. How for physics in anesthesia, we have to remember almost all things, especially she's confined to gases and fluids. So now we'll over to Dr. Anusha Gupta for his speech.
Sir, is my screen visible?
Yeah, madam.
Yeah, so, okay. So good evening all, and thank you for inviting for the talk. And today I'll be talking about physics and anesthesia. And as sir said, gases and fluids are really important for anesthetists. So we should know the basics of them as well. So I'll be short only except for like important things because it's a very vast topic. So we should know that even simple equations like force is mass into acceleration, pressure is force upon area, and force is pressure into area, and hydrostatic pressure is H rho g, that is the height of the column, and density and gravitational constant. All these things are very important in basics of our day-to-day practice. So what is gas and what is vapor? So anything pertaining to which is in gaseous condition and under normal room temperature is gas, but which is actually a liquid and is presently in vapor gaseous condition is called vapor. So so here comes the critical temperature. Like any gas below this temperature can be liquefied by applying either cooling or applying more pressure. So for oxygen, our critical temperature is -118 degree. So our liquid oxygen is prepared like that. And we see that for carbon dioxide and nitrous oxide, it is 31 and 36.4. So these two gases are liquid at the room temperature. So we get liquid in cylinders. So Antonox is a 50% mixture of oxygen and nitrous oxide. So as I told that below critical temperature gases are liquefied, but here in presence of oxygen, nitrous oxide also remains in gaseous form because critical temperature is decreased. This is called Poynting effect. It is because of the mechanical shearing when the oxygen goes through the nitrous oxide. Main thing is that whenever we are using Antonox, we have to be very careful that cylinder has to be properly mixed. Otherwise, if it is not properly mixed, then maybe we will have some liquid below, which will cause hypoxic mixture later on. So now we come to the gas laws. Gas laws are important because they help us in understanding the behavior of gases in different conditions. Like Boyle's law, here these laws are for the fixed amount of gas. And if the temperature is constant, then pressure and volume product is constant. That means P1 V1 will be equal to P2 V2. So this helps us in finding out the things. Then this Charles law, here they say when pressure is constant, then volume is proportional to temperature. And here we have to be careful, like respiratory volumes we are measuring, then if the temperature is changing, the volumes will carry the different value. Then Gay-Lussac's law here, again, when the volume is constant, then pressure is proportional to the temperature. So when pressure is rising, the temperature will also rise. So that is why, like, we have we have really good cylinder walls because the gases are in cylinder under high pressures. So if we expose them to high temperature, also the pressure will rise further. So there will be chances of exploding of the cylinder. So ideal gas equation accommodates all these three things. That is PV is equal to nRT. N is the number of moles of the gas, R is a constant, and T is the temperature. So when we bring T on the left hand side, PV upon T will be equal to nR. So if we see it carefully, then suppose we have an oxygen cylinder, then it will have a fixed volume. Temperature will be normal room temperature. So the pressure in the cylinder will be proportional to the number of moles of the gas. That is why whenever we measure the pressure, we have an idea that we take it as an amount of gas. So as the pressure decreases, we know that the amount of gas is decreasing and cylinder is getting emptied. So, but is it true for all the cylinders? We'll see later. So like in gas content, when it is a liquid oxygen, then 1 liter of liquid oxygen gives rise to 860 liter of oxygen in the gaseous forms. Normal pressure in the cylinder is 137 bar. So suppose we have a nitrous oxide cylinder. So here nitrous oxide is in the liquid form. The problem here is when we see the pressure gauge gives us the amount of the pressure of the cylinder. Like in oxygen, we said as the cylinder will get exhausted, pressure will come down. And but with nitrous oxide, it is in liquid form with some space which is left. Usually it is 90% filled and then 10% space is left initially in which the liquid gets vaporized. So when that space is left, so the gas will keep collecting, the pressure will remain the same, that is 745 psi, which is the usual pressure of the nitrous oxide. So how do you know how much is the gas in the cylinder? So that is by weight of the cylinder. So this is a filling ratio, is amount of the mass of the gas in the cylinder is as compared to the amount of water that cylinder will hold. That is 0.67 for nitrous oxide. So once the whole liquid is vaporized, after that only the pressure will drop down. So once the gauge is dropping, that means the cylinder is going to be empty soon. So we have to know the interconversion of the pressure to know the gauge, to read our gauges. Otherwise, it will be really difficult. Then there is Avogadro's hypothesis, which says that the equal volume of gas will have equal number of molecules. So 1 mole of any gas or vapor will contain 6.023 into, this is 23 is 10 to the power 23, not 1023 molecules. And the same 1 mole will occupy 22.4 liter at normal temperature and pressure. This helps us in calculations. Like nitrous oxide cylinder ka total weight, the total weight is 5.6 kg, and tare weight is the weight of the empty cylinder is 4.5 kg. So nitrous oxide is 1.1 kg inside. So we can calculate the volume by 1 mole will be 44 gram, will be occupying 22.4 liters. So our nitrous oxide will be 560 liters. So that gauge pressure is the pressure of anything excluding the atmosphere, at the atmosphere pressure, and absolute pressure includes pressure plus atmosphere pressure. So now come to fluids. When the fluid is passing through a tube, we have this important number called Reynolds number. We get a short note in the exam also. So it has it is equal to density, velocity, and the diameter divided by a coefficient of viscosity. And if it is less than 2000, the flow is laminar, and if it is more than 2000, the flow is turbulent. So what is the significance of this laminar and turbulent flow? So this is Hagen-Parsely's law, which applies to laminar flow. Here the flow is proportional, inversely proportional to the coefficient of viscosity. And this the fourth power of the, and it is related to fourth power of the radius. And when the flow becomes turbulent, then it becomes inversely proportional to the density. So in laminar flow, the viscosity is important, and turbulent flow, the density becomes more important. It plays part in flowing of gases or the fluids through the tubular structures. Like this is the first figure, shows the laminar flow. Here, see this center portion is the highest flow velocity, and gradually the velocity is decreasing because of the viscosity. And here it is the turbulent flow, which is an erratic flow. So when the flow is erratic, we get less effective flow. So it is we want laminar flow for our patients. So like suppose our example of these things is we are using a size of ETT. If it is not appropriate, the flow, the construction will make it a turbulent flow, and we will not have a good flow, this thing. So we have to have a good size DTT. Similarly, bends are not good. They make the flow turbulent. And like whenever there is a respiratory obstruction, then helium is used, because that time when the flow is turbulent, then density, decreased density of helium helps in maintaining the flow. Similarly, in flow meters, we have tapered flow meters. So with low flow, the viscosity plays a part, and when the flow is high, orifice is bigger, then the density plays a part. So this viscosity, the coefficient of viscosity is because of the friction between the layers of the fluid. So the coefficient of viscosity is shear stress upon shear rate. So this ratio, shear stress upon shear rate, remains constant, irrespective of the amount of stress or the flow. So this is called Newton's law of fluids, and this is called the fluids which follow this are called Newtonian fluids, like air and water. While blood does not follow, that is why it is called non-Newtonian fluid. So now we are talking about the flow of fluids. So there comes equation of continuity. Equation of continuity is the concept that whatever is going is coming out. So at one time, same mass of the fluid is passing through a section. So that is why they say that A is area and V is velocity. AV is constant. So A1, V1 will be A2, V2. So whenever there is constriction, there will be increased velocity. Constriction means smaller area, the velocity will increase. So this is also related to Bernoulli's principle, where they say that increase in flow velocity will lead to reduction in pressure. So we have a combination of increased velocity and decreased pressure. This leads to Venturi effect. Like when we introduce a constriction, then velocity is increased and pressure is less. So this less pressure leads to entrainment of the surrounding things. So we can use this Venturi effect in many things. Like when we do Pethick test for the Bain circuit, this is used. Then that Venturi mask for the oxygen, where oxygen and air entrainment to create a mixture is there, depending on the constriction available. And then this nebulizer also, like this center. This center is the driving thing with high velocity, and from here we get the entrainment. So similarly, nebulizer also has the similar principle, where the oxygen is the driving thing, and the drug or whatever we want to nebulize is atomized into small particles and mixed and entrained. Then this flow meters I talked about, that we have the usually used flow meter has a tapered tubes in which we have a bobbin. So when the flow is opened, the bobbin rises, and the this 0.09 kilopascal is the weight which has to be balanced. So the orifice usually with the tapering thing, the orifice increases gradually, and the bobbin remains balanced, and we can read the flow. And similarly, pressure regulators, they work on the principle that force is equal to pressure into area. So when the cylinders have high pressure, relief valves and pressure regulators decreases the pressure. So the high pressure when acts as a small area, later on the later part where the same high the area is increased, so pressure is decreased. This is the main principle. And then these Dalton's law of partial pressure says that partial pressure of each gas is proportional to fraction of its fractional concentration. So if one gas is in the chamber or the four gases are in the chamber, total pressure is equivalent to the total of all. Then this Henry's law, this says that the amount of gas dissolved is equivalent to the this partial pressure of the gas. And then Graham's law is there, which says that rate of diffusion is inversely proportional to the square root of the molecular weight. And Fick's law says that it is proportional to the area and conservation difference and the distance. So all these things tells us that diffusion is important, that like CO2 is more diffusible than oxygen. So usually respiratory problems we do not have CO2 problems. We have CO2 type 2 respiratory failure we encounter when patient is having obstruction, usually not in diffusion problem. Similarly, when we are using giving anesthesia and the gases diffuse into the circuit, and when the flows are that inhalational agent is turned off, then they diffuse back. The second gas effect of the nitrous oxide is also because of the similar thing. And then among physics, there are a few other things which we have to read, like humidity, like absolute humidity and relative humidity. Absolute is the amount which is there, water vapor, and the relative is the amount of water vapor as percentage to the amount of water vapor which saturated condition, amount of water vapor in the saturated conditions. And this heat moisture exchanger device also uses is a simple device used for maintaining humidity of the patient, in which there is a hygroscopic material which actually retains the heat and moisture of the patient's breath only, but we have to be careful when to change it because it gets clogged. That's it. Thank you.
Actually, the physics in anesthesia, especially pertaining to the gases and fluids, normally the physics in anesthesia itself is the toughest thing. Actually, we the anesthetists, even if we read many times also, it is very difficult to understand physics in anesthesia. So many times we have to by heart and all these things. Especially today, Anusha Gupta has given so nicely the physics in anesthesia, especially gas laws and all these things. Everybody has to understand all these things, because actually normally we the teachers, we the professors, we this one going to ask this question in the Viva. Actually in the Viva, with the machine, normally machine will be there in this. The preferable question supposed to be how you are going to apply the gas laws in the machine. Either is anything supposed to remember from Boyle's law. That is, you have to go back to the 12th standard or to the 12th standard, or we are going to call it the PUC. What are the gas laws? Physics. So we have to remember Boyle's law, Charles' law, Avogadro's laws, Pascal's laws, and all these things. Either we have to remember all these things. How we are going to apply with the machine and all these things. Anesthesia machine, how far we are going to be this. Every day we are working with the machine so many times. You are not well oriented with the gas laws and all these things, application of gas laws in the machine. Top to bottom, from the cylinders to the flow meter the vaporizers to the last to the exhaust pop-up wall. How the gas laws are going to apply. Nicely given by Anshu Gupta today. If at all you remember, you listen to this talk and remember, it is more sufficient. There is no need to talk or need to read once again for the exams and all these things. Definitely, it is the more important. No doubt. Thank you, Anshu Gupta, for extensive talk. Not only talk, explanation and also application, the gas and this thing, very nice of it. Thank you very much once again. Now we'll go to the next speaker, Dr. Nishant Kumar. He is going to talk on the applied physics in what you call monitoring. How we are going to apply the physics in monitoring, where we are it may surprise that monitoring also has got a physics. I say physics has to remember even for a monitoring, so we have to remember it. So now Dr. Nishant Kumar is going to apply physics in monitoring. We'll wait and see how he's going to apply the physics in monitoring. Over to the Nishant Kumar.
Good evening, sir. Respected chairperson, office bearers of ISA Pudukkottai, and a big thanks for inviting me. Dr. Sundaram has spoken elaborately about me, and I do hope that I live up to these expectations. Now, don't be intimidated by the figure on your screen, the great Albert Einstein, who's considered the master of physics. Now, I don't know how many of you have seen the recent sitcom, The Big Bang Theory. The protagonist in that serial, Leonard and Sheldon, they say that physics is there in our everyday tasks. Now, we all do monitoring day in and day out. In fact, no one monitors the patient as an anesthesiologist too. And all the monitors that we use are based on the physics, the principles of physics that we have read in class 11th and 12th. So don't be odd. I'll be just taking an overview. The details actually are not very much required, but it is something that we should be knowing about. And you do get a question at times, theory questions. and some odd examiner may just ask, okay, tell me what is the principle, the monitors that you're using day in and day out. And it is also better to know that the devices that we are using, how do they actually work? So coming to the most important monitor, the ECG. We all do ECG monitoring. That is one of the mandatory monitors that the ASA recommends. So the first task that we do while doing ECG monitoring is we apply these stickers, these adhesive pads. Now, if you see, this is the usual adhesive pad with a button thing, and adhesive. Sorry for the voiceover clock. Now, if you see, these come in various shapes and sizes, but if you see, there's an adhesive gel here, the adhesive part here, which sticks to the body, and then there's a disc in the center. Some do have this foam. Now, this disc is the important part. This has a conductive jelly. Now, we all know that there's a conductive system in the heart. There's exchange of ions, and that is how the conduction system works, and the systole and diastole occurs, or the cardiac cycle occurs, leading to the function of the heart. Now, all these things, we know that the movement of the ions creates electricity, generates a potential, voltage, current, whatever. Now, we know V is equal to IR. It has been talked about earlier also. Voltage is equal to current into resistance, right? So whenever there's a potential difference, there's a difference in the charge, whether there's a difference in voltage, the current will flow through. Now, the purpose of these electrodes is to capture this change in the electrical conductance of the body and relay it to the monitor. These discs are ideally made up of silver and silver chloride, Ag and AgCl2. Although their cheaper ones may contain lead, although the silver ones provide the best quality or the image acquisition of the chart. Now, what happens is that the electrical conductance, which is there in the body, when you apply this to the body part, there's a conductance or the potential difference travels through this, generates a current, and that current is carried to the monitor, where it is analyzed with the computer and portrayed in a graphical form. Now, we know we have the button forms and the clamp forms, which the leads that we apply to these electrodes. These are called electrodes. Now, this is the one which is sort of a dry. This one is a foam-based, which has a liquid. The foam-based liquids might cause allergic reactions, itching, and all those things. And remember, the silver ones are better than the lead ones. So probably if you're buying, the silver ones might be a bit costlier, but they will give you a better ECG image. Sometimes we say that, okay, the image is faltering, the baseline is not stable, there's a lot of electrical disturbance. So that is because if we go into it, this is a separate lecture altogether, that how do they actually work. But remember, the silver ones are the better than the lead ones or other materials. Now, how this ECG is acquired. Sorry. Just try to hide the controls so that if you see that this is a normal ECG with the P, Q, R, S, and T waves, right? And what we do is that there are two electrodes for which the current is measured. Now, for the leads 1, 2, 3, AVR, AVL, and AVF, that is the standard leads and the augmented limb leads, we measure on the surface in a superior to inferior direction. And for the chest leads, we measure the traversing of the current from the mid chest to the anterior chest, that is in the anterior posterior direction. Okay, so that is how we measure the current, and which gives us the graphical form of the ECG. Now, normally we put 3 electrodes, that is one on the left arm, one on the right arm, and one on the lower leg. So that gives us the standard leads, that is lead 1, lead 2, and lead 3 on the ECG. I'm not going to talk about the peculiarities of ECGs, but actually how the image is required and how it is done. Now, if you see that when we talk of lead 1, there's a negative electrode and a positive electrode. The negative electrode is considered the reference electrode, and positive electrode is considered the sensing electrode. So the current flows from the negative to the positive electrode, lead 1. So the current direction which lead 1 senses is from here to here. Now, if we see this diagram in the heart, the vector for lead 1 is this, that is 0 degrees. So it cuts the heart at 0 degrees. Lead 2, the sensing is lower limb, left lower limb, and the ground is right arm. So if we see the direction of this is 60 degrees along the axis of the heart. That is why we say that whenever we have to report on any abnormality of any of the waves, we see it in lead 2. Why? Because this gives us the exact orientation or the net vector conductance of the heart. So we are looking from here, from in this direction. So if you see, the entire conduction system of the heart is represented by lead 2. That is why we say that we should always, if any one lead which we have to monitor, we should monitor lead 2. Similarly, if we look at lead 3, it gives us from the lower limb and the left arm. We are looking from the lower limb. Lead. Yeah, sorry. Yeah, so we are looking from the lower limb towards the left arm, and if we see the vector here, we see that we are looking obliquely. That is why we see some of the waves which are inverted. Now, if we see at the augmented chest leads, augmented limb leads, that is AVR, AVL, and AVF. Now, here what we do is we have a we take these two. When we are talking of AVR, we are looking at the heart from the top, from the right atrium, in this direction, right? This is the direction that we are looking at, and the reference electrodes become the left arm and the left lower limb. When we looked at the AVL, we are looking like this. We are looking from the left arm towards the heart, and the reference electrodes become your other two, that is right arm and lower leg. And for AVF, we are looking from the bottom, from the lower leg towards the vector which is formed by the right arm and the left upper limb. That is, this is the vector which is formed by the right arm and left arm, and we are looking from the bottom. So we are looking the heart from the inferior bottom. Okay, so that is how we.
சத்துமாவு கஞ்சி இருக்கு குடிக்கிறீங்களா? சத்துமாவு கஞ்சி இருக்கு குடிக்கிறீங்களா?
I think there is a disturbance.
So that is how we acquire these leads. Always remember, we all have read about Einthoven's triangle. That is right arm to left arm. If you see negative, negative, positive, negative, and positive, positive left leg. So lead 1, we are looking from the left arm. Lead 2, we are looking from the left leg towards the right arm, and lead 3, we are looking towards the left arm from the left leg, and that is why we have these vectors, and limb leads are a combination of these two. So if you remember this particular diagram, we know that how the heart is being captured by our ECG. Always remember, as I said, any depolarization of the heart which is occurring from the reference electrode to the exploring electrode causes a positive deflection, whereas if the vector of the heart, the conductance of the heart is away from the exploring electrode to the reference electrode, we have a negative deflection. That is why in AVR, since we are looking from the right arm, where all the deflection is occurring from this side to this side, Whereas we are looking from this side, we have all the amplitudes negative in ABR, right? So that is how the ECG is acquired. The conductance is there, the current is measured, it is amplified and reflected on the monitor. Now, something about the paper. This is also very important, and I'll relate an interesting incident behind it. Now, we know that this is the ECG paper, everyone has seen it. It has some small squares and large squares. So the small squares is 1 mm and a large square is 5 mm by 5 mm. Now, the paper which runs through the machine is always 25 millimeters per second. That is, in 1 second, you'll have 5 of these boxes which will run through the machine and a tracing will be obtained. So that makes that 1 mm represents 0.04 seconds. So each box represents 0.04 seconds and a large box presents 0.2 seconds. Naturally, if it is 0.04 seconds into 5, this is 0.2 seconds. 0.2 seconds into 5 is 1 second. So 25 mm per second. Please check that. Whenever you're reading an ECG strip, please always check the speed at which the ECG has been taken. Because the machine, you can alter the speed to 50 millimeter per second and 100 mm per second also. Also check for this standardization graph which is there. Now this says that 1 millivolt is equal to 10 mm high. So this should be 10 small squares. Okay. So this is a reference electrode, and again this should be 1, 2, 3, 4, and 5. So 1 large square width and 2 large square height indicates that this is that 1 small square will represent 1.1 millivolt. So that is how we ascertain how much is the ST depression or elevation on the basis of that. Now the interesting fact is that there was this patient who went into atrial fibrillation. Now I wasn't sure on the monitor whether there was a P wave or not. So I was on call. I asked my resident, okay, since you're not sure, even on the ECG paper, the P waves are not nicely visible. What you do is you take out the ECG on 50 millimeter per second speed so that everything is double, and if there's a P wave, we'll see it. The resident does it. Unfortunately, the patient belonged to the gynae department. The gynae SR came, saw the ECG. The heart rate was around that time, because of the maneuvers and everything, it had come down to 75 per minute. Okay, the rate had settled by the time my resident had taken the ECG. Now she saw the ECG. Since the speed was double, the heart rate was halved. So she saw that the heart rate is 37. They panicked. They went and had a medicine opinion. The medicine SR saw the ECG, and it was a Sunday. Had I not intervened, the patient would have been shifted for a pacemaker insertion. So always please check, because the medicine person said, this is a heart block. This is a complete heart block. The heart rate is 37. This patient requires an urgent pacemaker. So please check your speed of the paper and only then interpret the ECG. If this standard reference is not there, if the speed is not mentioned, ideally you cannot report and read an ECG. In fact, even on the monitors, you have the speeds 12.5 millimeters per second, 25 millimeters per second, and 50 millimeters per second. On the monitor also, we usually set the speeds for plethysmograph and ECG at 25 millimeters per second, and for the ATCO2 at 6.25 millimeters per second, so that we can see more of the capnographs on the monitor. So please always check what is the speed of the waveform on the monitor and on the ECG paper. I hope I'm clear about ECG. I'm not going into the nitty-gritties and the changes in ECG. That is a separate class altogether. Now, another important aspect is the pulse oximeter. So that is one of the most important thing that we use day in and day out. If not any other monitor, what we use is a pulse oximeter. So what does a pulse oximeter, what does it tell us? Does it tell us the oxygen content of the blood? Yes, in a way. It tells about hemoglobin, which is present in the oxyhemoglobin and deoxyhemoglobin form. So what actually the pulse ox tells us is, what is the percentage of hemoglobin which is oxygenated? So if you see this first figure, now there are around 16 molecules of hemoglobin, out of which 8 are carrying oxygen, 8 are not carrying oxygen. So the SpO2 will be shown as 50%. Here, 12 are showing up with oxygen and 4 are without oxygen. So if we see the ratio of oxyhemoglobin and deoxyhemoglobin, it is 75%, which is what is reflected in our SpO2. This is what SpO2 means. Similarly, if all the hemoglobin molecules are oxidized containing oxygen, so it will show as 100. So how do we measure it? How do we know how much is oxygen and how much is oxygenated hemoglobin, how much is deoxygenated hemoglobin? Now we all know this is the usual cut section of a pulse oximeter. It contains a light source. Actually, it contains 2 light sources and a light detector. One is the red light source and one is the infrared. We'll be talking about it later. And it emits a light with a fixed wavelength, which is detected by the detector here. Now, this is called as transmittance because it is being transmitted and read by the other electrode here. The other one is the reflective, where the light is emitted. The finger is here. What happens is the finger is here. So some is absorbed and the other light is reflected back, and the emitter only reads what is being reflected. Okay, so the most common types that we use are the transmittive types. Here, as you can see, the light is being emitted. Some is being absorbed. 4 wavelengths are there. Out of these, 2 have been absorbed and 2 are reaching the detector. So this is a basic fundamental how it decides. Now, as I said, some of the light which is being emitted by the LED is absorbed by the finger. Now, exactly is absorbing the light? It is the hemoglobin. So hemoglobin absorbs the emitted light. Now, absorption of the light which is being emitted will depend on the concentration of light absorbing substance. Sorry. So more the hemoglobin, more light will be absorbed. Okay. And how much the distance the light has to travel through to reach the detecting electrode, that will also that will also depend on the absorption will increase if it has to travel a longer path. Okay, so the concentration of this light absorbing substance is governed by the Beer's law. So if more is the concentration, more light will be absorbed, and Lambert's law is that if the length is more light will be absorbed. So the pulse oximeter uses a combination of the Beer and Lambert's law called the Beer-Lambert's law. Now, as I said that we are emitting 2 lights, that is red light and infrared light. Oxyhemoglobin and deoxyhemoglobin absorb the red and infrared lights differently. How? We'll see later. Now, as I said earlier, if you see here, now these 2 fingers, they contain a different amount of hemoglobin. If you see, the hemoglobin is less here, so more amount of light passes through, less is absorbed. Here, the hemoglobin is more, so more light is absorbed and less passes through, which is the Beer's law. In this, if you see, the artery is vasoconstricted. Although the concentration might be the same, the hemoglobin concentration is the same, but if you see, the artery is vasoconstricted, so less light passes through it, less light is absorbed and more is detected by the detector path. And if it's a normal caliber artery, capillary, more light is absorbed and less is left to the detector. That is why if you have vasoconstriction, if the peripheries are cold, you do not get the correct reading of your pulse oximeter, right? Now, as I said, that pulse oximeter emits two lights, that is the red light and the infrared light is usually not visible. Infrared light is normally not visible to the naked eye. Okay, the wavelength red light is 650 nanometers, and for the infrared light, it is 950 nanometers. We have the deoxyhemoglobin curve and the oxyhemoglobin curve. Now, if you see, the absorbance at different levels is different. How? Now, if you see, the absorbance for oxyhemoglobin is more for infrared light, and it is for the deoxyhemoglobin, it is more for red light. So if you see, if we combine these two figures, what happens is that infrared light is absorbed more by the oxyhemoglobin and red light is absorbed more by the deoxyhemoglobin. So if the concentration of deoxyhemoglobin is more, red light will be absorbed more, and if the concentration of oxyhemoglobin is more, infrared light will be absorbed more. So what it does is that it detector plate detects that how much of the red light is being absorbed and how much of infrared light is being absorbed, and based on that ratio, the calculation of absorption of red light and infrared light on the mathematical formulae and algorithms, it gives us the value on the monitor. Now, if you see here, now this is a very nice graph. As you see, as the absorption of red light increases, what is happening? The SpO2 is falling, right? As the absorption of the infrared light is increasing, the saturation is increasing. So as I said that the oxyhemoglobin absorbs more of infrared light and deoxyhemoglobin absorbs more of red light. So basically, it is the ratio of the absorption of the red light and the infrared light, which is displayed by the pulse oximeter, and in turn, which tells us how much is the deoxyhemoglobin and how much is the oxyhemoglobin in the capillaries in the fingers. So that is why we have the confounding factors: a vasoconstricted patient, cold peripheries, and ambient light. Now, when the ambient light is leaking through into the capillary and the emitter and the detector, the ambient light will also contain some amount of red light and infrared light. As we know that white light, which is there, is a combination of all the wavelengths, right? That is one of the Newtonian principles. So when there is an interference, or if there is a bright light at the detector, what will happen is that some unmeasured amount of red and infrared light will be detected by the pulse oximeter, which is not there initially. So that is why you might get wrong readings if the ambient light is too much. So the best thing is to protect it from the ambient light. That is why we say that if the probe is not covering the finger properly and if there's a bright light outside, the pulse oximeter readings might be wrong. Okay. Now, we all take blood pressure. We all take earlier there used to be the mercury manometers, the aneroid manometers. Now what we are having is the oscillometric and the automatic ones. Every household nowadays usually has one. So there's a cuff, there's a deflation valve, there's an inflation valve, a source of pressurized air, a transducer, a microprocessor, which gives us the value. How is the NIPV measured? Now, what it does is that a cuff is tied to the artery where most common site for blood pressure measurement is your brachial artery. So that is why the cuff size location has to be precise. Otherwise, we'll get wrong reading. So what the machine does is that it pushes air into the cuff, it inflates. Now what will happen to the artery? As air goes into it, what will happen? the blood inside the artery will oscillate against the pressure which is being applied against the artery. So that there's a measurement, there's a transistor. Sometimes it is in the cuff, sometimes it is in the machine itself. Now, as the pressure rises, the pressure might rise linearly or in steps, like in 2 mmHg, 4 mmHg, 6 mmHg. Now, if it rises in 1 mmHg steps, it's better. The lower step it rises, the better it is. Linear rise is obviously better than step rise of pressure. Now, what happens is that at some point, what will happen is that there will be a total occlusion of the artery because the pressure outside is occluding the artery. So there will be no oscillations. And that is how we measure our palpatory systolic pressure. Because at the pressure at which the artery is occluded, that means that is the systolic pressure is reached. Now what happens is it reaches a particular pressure where there are no oscillations, and then gradually the cuff is deflated. Then at the point where the oscillations start to increase, if you see this here, it is the oscillations have started. Now where there is a major increase in oscillations, first major oscillation is the systolic pressure. At a point, there will be a point at which the oscillations of the blood would be maximum. This gives you the map, and the point where the oscillations tend to decrease in the cuff, in the artery, is your diastolic pressure. Now we know that the mean blood pressure is equal to systolic blood pressure plus 1/3 of diastolic blood pressure. So some devices, what they do is that they measure the mean arterial pressure, mean blood pressure, and systolic blood pressure, and the diastolic blood pressure is usually calculated. Okay, so that is the formula that is used. It has been seen through studies. That is how the relation between mean blood pressure, systolic blood pressure, and diastolic blood pressure goes, and that is how it is calculated. Now, based on this principle, we have our own ways of deducing the blood pressures. How do we do it? We normally put the pulse oximeter in the same finger. We increase the cuff pressure. The pressure at which the pulse oximeter reading disappears is the systolic blood pressure. Then at which the pressure after which the SpO2 does not increase, the platelets of graph does not increase, or the amplitude of the graph does not increase, is the diastolic pressure. We all do that in the OT at times. So this is the basic principle. This is all about the oscillations, and that is how NIBP is measured in the machine. Okay, ATCO2. It is often said that if you have the choice of all the monitors and you can have only one monitor, the one monitor that you would like to have is an ATCO2 or gas monitor. Now, we know that we have the mainstream sensors and the side stream sensors. So there are three principles which are used to measure the gases. Now, infrared can be diverting or non-diverting. As I said, non-diverting is the mainstream, diverting is the side stream one. What it does is, again, there's an infrared source. There's a cuvette. Everyone has seen a mainstream one. Okay, there's a cuvette with a removable piece which is there. There are two circles which are there in the cuvette. Okay, so there's an infrared source in the console which is there, and air passes through the cuvette. Now again in the console which is there, what happens is there's an infrared source, a measured wavelength is passed, and there's a detector here. So what happens is that each gas has an ability to absorb a particular wavelength, right? So now there are different wavelengths which are emitted. Now, if it's a CO2, it's a different wavelength which is emitted. If we are monitoring for the gases, the halogenated gases, we have the different wavelengths which is there. Now, infrared source is usually used for gases which have dissimilar atoms. So carbon dioxide, your halogenated, nitrous oxide, all these can be measured, but not oxygen. It's a single atom. Okay, so what it does is the absorption pattern will depend again on the density of the gas present there. So as we all know, this is the patient circuit. The patient exhales from this, CO2 passes through this, and the infrared source is, there's a continuous bombardment of the wavelength which is detected by this. And based on the concentration of the absorbed wavelength, we have this display on the monitor. Similarly, in the sampling, there's a pump which takes around 100 ml of gas into this chamber, where it analyzes the different wavelengths and gives you the concentration or the partial pressures of the gases inside the breathing circuit. Now, this is the most common one and the most adaptive. Remember, infrared source, we know that infrared produces heat. So, if you feel that mainstream sensor, it will always be warm. So it can cause burns and other injuries which you have to be careful of. Now, if there is dirt or mucus plugs or any dirt in the any organic matter on those two circles, you'll get a different reading and your reading won't be accurate. Now, another problem with infrared source is that nitrous oxide interferes with the detection of the CO2. Now, most of the newer machines which we have, they have an auto nitrous oxide corrector. But if you go to some older monitors, they will say whether you're using nitrous oxide or not. And if you're using nitrous oxide, what is the percentage of oxygen that you're using, so that it decides how much nitrous oxide is being used and it applies a correction to the CO2. So if you feel that your PaCO2, EtCO2 is not matching, please look at your monitor in the settings, go to the EtCO2 settings and see whether you have set this, whether your monitor requires it to be set for nitrous oxide correction or not. Okay, that is very important in some of the monitors, the older ones specifically. The other one is the Raman spectrometry. So C.V. Raman, we know the Nobel laureate, won the Nobel Prize for scattering of molecules in 1931. He basically explained why the sky looks blue and the water appears blue because of that, and dusk is orange, dawn and dusk is orange and sky is blue. So we have a laser which emits a monochromatic light. Now we know the Tyndall effect. Now when a monochromatic light strikes the particles, it is scattered in different wavelength and it will depend on the composition of that particular gas, the density and the percentage of the gas which is there and the structure of the molecule which is there. So again, the monochromatic light which is emitted, the pattern of scattering of the wavelength is observed, and hence we get the partial pressures of carbon dioxide, nitrogen, oxygen, nitrous oxide, and up to 3 anesthetic agents. But usually these machines are bulky and used only for experimental purposes. The other one is mass spectrometry. So here we use, we can use gases which have 2 atoms. Now oxygen, nitrous oxide, carbon dioxide, volatile agents, they have 2 or more atoms. Argon, helium, they are single atoms. Okay, so there is no bond between the atoms in argon and helium. Oxygen occurs as OO. So basically, you have to have a mass of the molecule and a charge. Charge comes from the bond. So what it does is that it spreads the gases according to the mass charge ratio, and again it measures volume percentage. So mass spectrometry, you can read about it. It's basically the charge which is there and the amount of mass which is there. The charge is proportional to the mass. So accordingly, we get the partial pressure of the gases, and up to 31 sampling locations can be used, again for your research purpose. Oxygen. Nowadays, we always say we are all fond of using low flow anesthesia and closed circuits. So we have to monitor the inspired and expired oxygen concentration inside the circuit. So we have 2 kinds of sensors. The commonest one uses the galvanic or the electrochemical, and the paramagnetic. Paramagnetic one is the costlier one. Now, paramagnetic means that when a gas passes through a magnetic field or a compound passes through a magnetic field, now we all know Maxwell's law that whenever there's a charge which is there, a difference exists it passes through a magnetic field and electrical current is produced. Now, what happens is oxygen is paramagnetic. Of all the gases that we use, oxygen is paramagnetic, that it gets charged in the presence of magnetic field. And the pressure wave which is produced when it enters a magnetic field is proportional to the partial pressure of oxygen. Now, what we do is we take the reference as air. We know that air contains around 20.8% of oxygen, although the same cannot be said about Delhi and Mumbai nowadays. We must be breathing much less because of the pollution. But that is the reference that we take, 20.8% of oxygen is in the air. So that is how it is calibrated. And we know that the pressure wave created by 20.8% of oxygen is there. And when a sample gas passes through it, magnetic field is produced, which produces an electrical signal, and the strength of the electrical signal is proportional to the amount of oxygen present. So that is how we get the FiO2 and end-tidal oxygen from this paramagnetic. Now, this contains, since it's a magnetic field and an electric current is provided, the magnet does not wear off. So it gives a very good long-lasting life, but it is costlier and it is essentially temperature dependent. So there's a heater there and a particular temperature is maintained in the case where the paramagnetic sensor is kept. Now, the most common one is the electrochemical or the galvanic, where we have the lead anode and the gold cathode, which is surrounded by potassium hydroxide electrolyte solution. Cathode is sensing electrode and not consumed, which is the gold. And anode is what happens is at the cathode, oxygen plus water plus 4 electrodes. So oxygen is reduced to hydroxyl ions. The hydroxyl ions react with lead to produce lead oxide, water, and 4 electrons, which again take the help in the reaction at cathode. So more the oxygen, more reduction, more production of lead oxide and electrons. So as we know, electricity or the current is nothing but flow of electrodes. So more oxygen, more current is generated. That is again measured and we see the value. So remember, the moment it is exposed to oxygen, this starts working. So normally this has a life of around 6 months. Usually it is supplied in a vacuum truck. The moment you open it, it will start working and the lead anode will start getting consumed. Over a period of time, it gets weaker, and that's why you have to change it every 6 months, right? In all the anesthesia machines. So if you're buying an anesthesia machine, all the paramagnetic will be costlier, but that will last you a longer time. So electrochemical, again, if not in use, please let it be exposed to the lowest concentration of oxygen possible. That is, you leave it to air rather than keeping it in a high oxygen environment. Okay. Okay. Temperature monitoring. Again, there are 3 principles which are used. Thermistor. We know that electrical resistance of certain metals varies with temperature. As the temperature increases, the ionic activity increases, which produces a current, again, which is measured, and the resistance or the flow of the current is measured and converted to temperature, which is against a temperature. So normally the skin probes are usually a thermistor. Then thermocouple, if you remember, we have all read this in class 11 physics. Thermistor, thermocouple, and the Newton's law of thermodynamics. So these are the 2 wires of different metals. One end is at the metric side, other is the reference temperature. Now, if there's a difference in these temperatures, what will happen? Since these are at different metals and different temperatures, there will be a current flow if there's a difference of temperature. And more the difference of temperature, more current will flow. So this again, the current is measured, which is translated to your temperature in the monitor. The other one is the infrared. Again, as we said, that infrared emits heat. The ear ones that we use for pediatrics is the infrared sensor for temperature. So these are the common ASA monitors that we use and are mandated by American Society of Anesthesiologists, which are to be used for each and every case, and that is how they work. Now, if time permits, with permission, can I go with the pressure transducer? Because that is
okay, Nishant. I think you can finish it off.
Yeah, I'll just take 5 minutes for this.
Yeah, please.
Okay. So the pressure transducer is the one that we use for invasive monitoring. Now it is based on a very simple principle of the Wheatstone bridge or the strain gauge, where we have 4 electrodes. Remember in class 12th, we did extensive experiments in physics where we had to find the unknown resistance. It is the same. We have R1 and R3. Okay. We have the voltage here, which is supplied in this. These are in parallel and these are in parallel. Okay. So these 2 resistance we know. Third one is a variable resistance, which we calibrate according to the pressure which is there. And the fourth one is the unknown resistance or the patient's pressure that we have to measure. Now remember, any change in pressure will again produce a change in resistance, will lead to a flow of the current. So R1 and R3 are known. R2 we calibrated with the pressure, we open it to air, we zero the Rx. Okay, and then when we connect it to the arterial line, depending on the pressure, it is simply given by the formula R2 by R1 equals Rx by R3. Now we know R1, we know R3, we know R2, Rx is calculated. Okay, so we have the signal that is from the arterial catheter goes to the coupling system, that is the tubing, pressure transducer, which is amplified. As I said, the current is produced, it is amplified, it converts the analog to digital, which gives us the waveform and the number microprocessor, and ultimately the image is displayed. Now, whenever there's a pressure wave, it is made up of fundamental frequency and a series of harmonics which are in phase. Now, pressure is always harmonic in a sinusoidal waveform. Fundamental frequency usually equals to the heart rate. Frequency is 1 upon n. Okay, so fundamental frequency and first 10 harmonics can obtain a rough approximation of a pressure waveform, and most of these information of pressure waveform are contained in the range of 0 to 20. Now, if you see, what it does is that it collects the various resonance. These are the waveforms which are produced, amplitude, and from this, by amplification and by a process of your algorithms, it produces a single wave. So normally 4 to 8 waves are used, oscillatory waves are used, and it produces a single wave, and which is produced on the graph, and from this the pressure is calculated. Now we often talk of damping, right? So if this is a normal waveform, what happens is, underdamped means that if there is a long tubing on increased vascular resistance, what will happen is that you'll have a high systolic blood pressure, but a lower diastolic blood pressure. But always remember that the map remains the same. Okay. Overdamping, we often see that the waveform is, this is a normal waveform. We don't get a peak, we get a curved waveform. Okay. So it gives is a lower systolic blood pressure, a higher diastolic blood pressure, but again the mean arterial pressure is the same. And the causes are air bubbles, overcompliant tubing, blood clots, catheter kinks, stopcocks or injection ports. There's low pressure in the flush bag. So all these will cause a overdamping. Overdamping means that the peak is being slurred. Underdamping means is that there's a accentuated peak. But always remember, although the systolic and the diastolic blood pressures might be different, the mean arterial pressure always remains the same in both the things. So following, we always used to end our mathematical problems with QED, Quo e Demonstratum, what was to be demonstrated. So I hope that I've sensitized you to the basic functioning of the basic monitors. Thank you, and I'm open for questions.
Thank you, Dr. Nishant Kumar. Actually, you specialize, no doubt, with application of physics in monitoring, day-to-day monitoring. We are using monitor live. Without monitoring properly, we cannot do the case also. We are so addicted. So we are well ventilated to this or well oriented to the this beautifully. beautifully, understandably, in detail regarding the each this thing like an ECG or pulse oximeter or gas monitoring or ETCO temperature and pressure monitor. Everything is in detail. You've gone up to the stage that is in ECG while explaining the ECG, how far the ECG lead is most important. So many times, even our port gadgets are not going to see the ECG lead, whether it is correct or not correct, and even whether it is in a jelly, is application of jelly is there or dried up, because they don't know the application. Once they applied over that, automatically there is a disturbance started with the ECG. Even the basic things, even they are not ready to this. This is one of the fantastic lesson for our port gadgets, well-known port gadgets, that how far we are going to each and everything in ECG, even lead. You told that regarding the speed of the ECG also. So many times speed is not correct and all this thing, interpretation will be going wrong. So automatically you told that patient has gone for bradycardia and they taken an outstreet resistance, they're gone for an what you called pacemaker. So many things. I think it's not a heterogenic problem because we are not well oriented, well arranged and all the things. So nicely you are in detail told what is the importance of the ECG, interpretation of the ECG, how the these functioning under ECG, how the anesthetic is supposed to be there with the ECG. It is one of the wonderful thing. It is a good thing for our this thing, and also pulse oximeter. Day-to-day pulse oximeter is a mandatory and all this thing, where the pulse oximeter and all these things will be there. Even sometimes, it has become a cold and all this thing, it is automatically not shown the wavelength and all this thing. So that is also heterogeneous. So many problems will be there. In detail, these are the things to be taken or anything to be remembered. Our postgraduate is supposed to be how the gas monitoring, especially with an ETCO2 monitoring, and also how far the temperature is, how the temperature, the leads at temperature 1 and temperature 2, how to take that. This one also most important. So pressure transducer also most important. So regarding all the things, monitoring, application of physics for the monitoring. So really, you're a master. I think ECG, when you're explaining, I remembered my days with this one. Really fantastically done. I think is well taken by our port graduates and all these things. And really thankful to you. Extensive and interesting and all this. You made this is interesting. So many times these are the subject where your application of physics in monitoring and all this, not at all interested. You made the topic very interested. And I think our postgraduates are well taken by our postgraduates. Thank you once again, Nishant Kumar, for a wonderful session. Now I think all
Chairperson, Dr. Venkatagiri, our past president and present academic chairman ISA is online. So he can give the comments. Dr. Venkatagiri.
Yes.
From a beautiful class. I enjoyed that thoroughly. Basics and really thoroughly enjoyed the class. Would like to see again. Really wonderful, very simple and like that. Everybody should know that. Very, very interesting. Actually, he wanted to hear the next that. I don't know whether that was over. By the time I logged in, I remember this was going on. Really beautiful lecture. Very nice.
Yes.
Thank you so much.
So,
yes, Mr. President.
Sir, we are happy that ISA National Academic Chairman is acknowledging ISA Budan from Pudukkottai.
Pudukkottai.
So
No doubt about it, sir. No doubt about it, because it is a well taken and all these things, doing very well, really well. And today the topic, I told it's the dry topics, or you are going to call hidden topics, and nobody has this one. You made it open to this one. So many people they're not going to be concerned much about this physics, especially with this anesthesia. So they are all the three speakers enlighten us, and also they made to understand that what the things to be, especially our postgraduates and all these things. So I think really no doubt about it.
Actually, sir, 76 people attended the webinar straight on the Zoom platform.
Oh, beautiful.
And there was initially a fire in their lecture. Then as there is a fire, then there was a fluid to extinguish that. Then we were really monitoring the physics of their subject.
Yeah.
And as if they have finished BSc Physics and joined MBBS, everyone delivered it extraordinarily well. And it says it was interesting. It is not delivering. It was interesting. We are really very happy. And see, absolutely there was no chat box questions. So if there is anyone to ask directly, because to ask doubt, they should know physics first. So, I think it is all the more difficult to ask a doubt in this, because now only so many people are understanding physics. It is really phenomenal. All the three have done very well.
Wonderfully.
Wonderfully well.
Sir, Mr. I think, so regarding before going to any questions and all this, I would like to ask all the three speakers what message they can give to our postgraduates, well-known postgraduates, take-home messages, because everything cannot be taken carry. And I can request them to give the take-home messages individually, if possible, please.
Basically, the take-home message is that now we always talk of these pulse oximetry, ECG. These are the basic things. Now, the trend has become is that whenever there's a problem, we turn to the technicians. Why? We should know what is the day-to-day monitors that we are using day in and day out. We should know what are the problems which are causing this. Unless until we know how things work, we are not going to take care of it. So for everything, okay, this is not working, you keep it aside, the case is not done. So there are some simple solutions to these things, and most of the times you don't require expert help to actually sort out these problems. So that is why, to know how things actually work. Now, I have not gone into the details of methemoglobinemia, sulfhemoglobinemia. Now, if we see what is the pathophysiology of sulfhemoglobinemia, methemoglobinemia, and carbon monoxide poisoning. Now, if we apply this to the ratio of oxygenated and deoxygenated hemoglobins, we'll know what reading will be shown onto the monitor. We need not have the Massimo monitor, which gives you the concentration of methemoglobinemia or sulfhemoglobinemia, or what are the errors that will creep in if we have patients with such poisonings and all. So as Sir said, suppose if there's a fire, there's a carbon monoxide poisoning. So what is the pulse of that is going to be, the saturation is going to be shown on the monitor.
Yes, sir. No
Dr.
doubt.
Dr. Nishant, I want to ask a doubt. Whether the books seen in your backdrop are the physics books you are reading, and it is a virtual screen.
Department library.
And it is a virtual screen.
Although I do have a huge library, again it is of English literature and Hindi literature. I'm very fond of literature. So the most of the books that you'll find in my room is basically literature, English and Hindi literature.
Yeah, no doubt about it. Sir, madam, I think, can you give madam and Anusha madam, can you take home messages, anything?
My take-home message is that small things we may not really go into details of physics,
Exactly.
but small applications which are very frequently asked, especially in table viva, with machines, with equipments. Those parts we have to know, and we have to understand what is applying where. That is very important.
What about Dr. Megha? Would you like to say anything about our postgraduates take home or anything?
Yes, sir. Sir, I think the take-home message for my lecture would be that we, the new generation of anesthetists, are so reliant on electrical devices and the new technology that we forget that they have certain complications which can occur by their use, and we forget how to work without them in situations where we can't use them, such as a fire. So I think it is important to know the complications.
Very nice of it. I think it is well known to the postgraduate, all the things, please, is beautifully conclude, beautifully told by this, all the three speakers. So you have to remember on all these things, especially for examination, even the machine, what are the laws, gas laws we are going to apply with the machines, and what are the safety measures, everything is in a physics, applied physics. Even here, probably, I think one thing I want to tell you, how the artificial intelligence, now artificial intelligence is also one of the prominent, upcoming, and all this thing. Doesn't mean that it is an upcoming. Even 1,500 years ago, also artificial intelligence was taken care in the Mayo's clinic. The patient, before register the things, he registered nearly about 350 investigations will be supposed to ready before he is going to be a consultant. If he's going to feed to the consultant, what he called the chair and all this thing, it's supposed to give the diagnosis. If you give the diagnosis, put it on the pharmacy chair and all this thing, it prescribe the drugs. So fantastically, 1,500 artificial intelligence, even in all our monitors, artificial intelligence is also involved. I want to tell, because nowadays everybody, there is a talk, there is artificial intelligence and all this thing. I want to add up for this. So our postgraduates, especially exam going, So machine with the gas laws, application of gas laws in the machine and all these things. So most important, all physics application and all the monitors, so nicely applied, so individually, so cleanly. So please, you will take on all these things. So there is no need to read once again for your exams and all these things. So now, I think any questions from the what do you call audience, or what do you call the speakers, or anything? I don't know. There is no thing in the chat box or anything. I don't know. Everybody is well understand the things, speak the talk and all these things. I think if there is no question, I would like to ask one question to the madam. How far your surgery department perform the annual fire drills and all these things in your hospital or anything, madam? The fire drills annually, how far your surgery department is going to perform these things? Anything?
Sir, if I may answer,
Yeah.
we usually have the demonstration from the fire department, the fire safety officer, and it is not usually in the OT. The evacuation plan is not carried out, but the entire residence faculty and the staff, we are trained almost every 2 months or 3 months how to use the fire extinguishers. We create a scenario outside in the open so that no one is hurt, and they demonstrate how to actually the pass pull this thing. You pull the pin and then you sweep and then you sway, all those things. So that is demonstrated, and how to use which kind of fire extinguisher to use in which condition of fire. We do have a fire safety drill every 2 months in our hospital.
Very nice, very nice. Because why I ask this question? So many, OT, they got a fire extinguisher. So many, we the people, we are not touched also. We doesn't know how to operate also. Even forget about us. Even we are not our port gadget. Even our OT boys, even doesn't know that. Simply it is hanging and all the things. So many times it will be there. When situation comes, then only they are going to think about this. In Kannada, there is a proverb in this. I don't know that. Benki hatkondaga, we are going to, after the fire, we are going to dig the well for get the water and all these things. So we have to demonstrate to our port gadgets, or even we have to ask that what is the drill for a port gadget, how we are going to open up. By chance, when you're doing, we are doing it actually, our example, we are doing on laser surgery, especially with this. Suddenly the fire has catched and all this thing. Even I'm telling you, our experience, fire extinguisher, they got the fire, they doesn't know how to operate it. No, I'm telling you, honest and all these. These are the things supposed to be taken care of in the OT and all these things. That is also most important with this. Okay, because we're running short of time and all this thing. Once again, thank you very much for the 3 speakers. Fantastically and very interesting is all the speakers from the Lady Irving Hospital, Irving College and all the things. Once again, and I will be grateful to our doctor, my beloved Dr. Meenakshi sir, and also the President ISC and Secretary of Pudukkottai, Bhutan, that's the thing, and ISC branch and all the things. They were given the opportunity, the much more, I'll be grateful to them. Thank you once again. I think Dr. Meenakshi sir wants to speak. I don't know that.
Yeah, I thank all the 4 faculty, because 8 o'clock is our finishing time. Now it is 7:57. So they were talking very well on physics, and the chemistry between the speakers and the audience worked out very nicely. So biologically we are happy. Now I hand over the session to our President Suresh Kumar sir.
Yes.
Thank you, ALM sir, for bringing this dry topic, a wet one. And I have 2 observations to make. First one, I am first time hearing a chairperson who have a wonderful style of English accent, a 5-star background, as though I was in a situation that I am watching the World Cup with the anchor. Your accent was very fantastic, sir. And the way you conducted the session, I liked it very much. Thank you, sir, for sharing the session. And regarding this, all the speakers, they have wonderfully done the job. As though I feel now I was a practicing physicist rather than a physician for a surgeon. So the way Dr. Nishant told that ECG and everything, I have not read about that. Thank you for all the speakers for bringing this topic, a live one and entertaining one, and very, very useful one. Now I invite our treasurer, Dr. David, to host a vote of thanks. Over to Dr. David, please.
Yes, sir. Good evening to all. On behalf of ISA Pudukkottai, first of all, I would like to thank our academic chairman, Dr. ALM sir, for selecting very useful topics for this webinar. Thank you very much, sir. And a special thanks to today's chairperson, Dr. Gangadhar sir, Professor and HOD, Sri Siddhartha Medical College, Tumkur, for nicely connecting and sharing his experiences. Thank you very much, sir. And also, I would like to thank today's speakers, Dr. Anshu Gupta, Director, Professor, and Dr. Nishant Kumar, Professor, and Dr. Megha from Lady Harding Medical College, New Delhi, for excellent academic session. And also thank other faculties and postgraduate and Accurola A1 Logics for technical support. Thank you very much. Thank you all.
Thank you. Thank you, sir.
Thank you, sir. Thank you.
Thank
you. A1 Logics can end the meeting.
Okay, sir. A1 logic. Still, I think we are on time. Even A1 logistic, probably, I think.
They have left, is it?
They also, logically, they've forgotten probably 8 o'clock. That is also point to be considered. Probably they're not looking into this thing.
You are in your house now?
Yeah, sir. I came from the college. That's the thing. I was little. I couldn't get into this thing.
We will not explain.
I straight away came from the college, from the Tumkur, and I get into there's a thing short of this one. That's all, sir. So, anyhow, thank you very much providing this.
Thank you, sir. We will end the meeting, sir. We will end the meeting. I thank Dr. Anshu Madam and Dr. Nishant for your constant support. So, we are really honored. And just because of people like you, academicians, we could run the show.
Yes.
They are really interested.
Thank you so much
because of the wholehearted participation. Yeah. It was really very nice because it is a dry subject. So we have asked you once more. Again, we will be asking you twice more. So,
Twice more.
Anytime, sir.
Thank you. We will end the